All right, we'll move on to our next speaker. Maria Kett is a professor of humanitarianism and social inclusion in the UCL Institute of Epidemiology and Healthcare. An anthropologist by training, she has extensive expertise in disability-inclusive humanitarian responses. Professor Maria Kett has undertaken research in countries across Africa and Asia, leading on a number of research programs on disability and international development, and is author of over 140 publications. She's also the program director for the UCL MSc in Humanitarian Policy and Practice. Professor Maria Kett also leads on the humanitarian-focused work for the Global Disability Innovation Hub. She regularly serves as a consultant for numerous bilateral and multilateral donors, including the UK FCDO, the World Health Organization, and the United Nations. Today, Professor Maria Kett will discuss the urgent need of assistive technology in humanitarian crises. Thank you for being here.
So long, thank you. I wave my arms around a lot, so I'm gonna put this. Is it okay to put it in here?
I think it needs to be close to your.
I wave my arms around. Apologize in advance. And this.
Try to use it. It doesn't work.
And to flick the next slides, I just do.
The arrows.
I'll give it a go. Let's give it a go. Okay, well, thank you, everyone. I'm taking us on a slightly different journey now. And I should at the outset say I'm not a technical expert on assistive technology. I'm not a physiotherapist. So this is very much coming at it from a sort of social science perspective, I guess. You've heard a lot from us already today, so you'll hear more. And I guess the other thing I want to underscore is that we've already heard a lot about the barriers to access for older adults in humanitarian crisis. So maybe assistive technology, although not a perfect solution, of course, is a way to facilitate access. And I think we perhaps forget that a little bit. It's necessary for some people to have access to this to enable wider access to the system. Now I'm also unable to move the slides. I'm going to sound like Chris Whitty. Next slide, please. Did you do that or did I do it? I thought it'd be worth just highlighting a little bit about the definition of assistive technology, because we all have a different understanding perhaps, but it's really important to say it's the products and services. So it's not just wheelchairs. We often think about the very common products when we think about what assistive technology is, but it's the products and services that enable people, especially, but not exclusively, older people and disabled people, to participate in everyday life. We've heard a lot about participation, but for some people, without these assistive technologies, that participation is very difficult. It does include mobility aids, such as wheelchairs and walking sticks, sensory aids, such as hearing aids and eyeglasses, but it also includes digital tools, and oftentimes we forget this, so mobile technology. And of course, the systems and services that support that, and I'll come into that into more detail. And I think this is the bit I want to really underscore. It's the gateway to education, employment, independence, and inclusion, and is essential for achieving the SDGs. The point being that without this, for many people, we can talk about participation all we like, but without enabling that participation through various means, it doesn't happen. If you're sitting in a group and you can't hear what everyone's saying, that's not participation, that's actually exclusion, because you're actually in a worse position. You're there, but you don't know what's going on. So it's really important. And of course, it can, of course, be life-saving, and I'll come back to that. I think we've also talked a lot about healthy aging, and we know that this is really important. We are, in general, as a population, globally, living longer, but we are not necessarily living longer in good health. And that's a really important issue. So for some people, these assistive devices and technologies will enable and support healthy aging and healthy longevity. Next slide, please. This has been going now. We've heard a lot about what isn't happening, but there has been some moves to try and support inclusion of people with disabilities and older adults. And Ria and I go back, I think, quite a long way working in this field. In 2022, the World Health Organization and the UNICEF put together the World Global Report on Assistive Technology. And just to underscore, in case you haven't heard this, it had recommendations on access to assistive technology in humanitarian responses, including efforts to ensure that people weren't disadvantaged in access, that they could be included within essential healthcare kits and trauma kits, that there were training materials that could be used. It was, and we've heard this word a lot, integrated and appropriate service provision to ensure that is that products were compatible with those who use them in the long term. And this is a really important point too. We often think about this as a very one-off provision, but it's not. And of course, and finally, emergency response facilities should be barrier-free and inclusive. I guess that's a really obvious point. Next slide, please. The WHO proposed a very useful framework to think about this, and it's useful if only to remind us that it's not just one area or avenue. And the WHO talk about the 5 Ps: products, the kinds of products that need to be used and developed in humanitarian settings; the people, that is not just the personnel to deliver AT, but also who uses and creates the assistive technology in humanitarian settings; provision, procurement, this is a really vital aspect of it. How is AT currently funded and how sustainable are these models? What existing and local supply chains, etc., are there? Place, how does location impact on access? And of course, use of assistive devices. And policy, how is it influenced by existing policy frameworks? And I think this is a really important framework because it makes us realize that it's not just the delivery of a one-off piece of device or product, but it's part of a much wider systems approach. Next slide, please. We've heard these data already before. It's an estimated that over 300 million people in 2025 alone need humanitarian assistance. According to the Global Disability Fund, over 45 million of those individuals are in need of assistive technology. Some people go a bit higher and say it's about 1 in 3. And I'll come to who those people are in a minute. But we know, and for example, in Gaza, we've already heard about Gaza. Sorry, go back one for me. That, for example, in Gaza, we've heard about the numbers of children who are experiencing amputations as a result of the genocide. We know that those children will grow up to become adults. They'll need to get education, they'll need to get jobs, and will need assistive technology support throughout their life course. And I think that's important. And we've already talked about Ukraine as well, and I'll come back to that. But it's really important to think about this as not a one-off provision. It's across the life course. Next slide, please. Now you can go. The other thing is, I think when we think about assistive technology in humanitarian contexts, we tend to think about people who are newly injured, who require some kind of assistive devices as part of that support. And that is indeed a significant number of people, unfortunately, through war or other injuries. While we do have more data about that group, and I'm sure MSF probably has some data about that group too, we actually don't know what happens in the longer term. We have very, very few, almost none that I could think of actually, studies about long-term impacts and how assistive technology needs change over time, or even what the impact of that assistive technology has had on people's lives. For example, providing wheelchairs, providing prosthetics, does it actually enable people to be and do what they want to be in their lives? Just giving somebody a limb, does it enable them to go to school? Does it enable them to get a job, to get on the bus, to go to the mosque? Does it enable people to do what they want to do in their lives? The second group that we think about are the people who had assistive technology, but who lost it. This is very common, and you can imagine in situations of humanitarian crisis and emergencies, people flee their homes, their families, and they leave behind their wheelchairs, their walking sticks, whatever. They often have to. If it's an emergency, you're going to. And this can be also, the infrastructure itself can be destroyed, and we certainly have some evidence of that from Gaza. The numbers of people who, this number in Gaza is a significant number actually, who had devices and provision of devices, but it's been lost. And the most recent situation analysis from Palestine clearly indicates that. The third group is perhaps the one we don't think about at all, actually. It's the people who have unmet need. Oftentimes they may be older adults who've never had an assessment to see if they need any assistive devices. And of course, not all of those people would consider themselves to be disabled. However, this group is often the one we forget about and is the one that's likely to be the most in the biggest group of need, actually. And just as a sort of aside, in a lot of these population level assessments, we don't include people living in institutions. In some countries, that can be a significant number of people with disabilities and older adults, and that changes over time as well. So when we think about who needs assistive technology and devices, it's worth thinking about it's a much wider group than we might immediately think. Next slide, please. Probably don't need me to remind you about the ISC guidelines. They do mention assistive devices and technologies. Again, they have this quite wide definition, including software. But the important thing to highlight from here is how Assistive devices improve functioning and independence and overall well-being, but they also help prevent secondary impairments and health conditions. And I think this is the bit, we've talked a lot about health conditions, but we often don't remember what's going to happen if left untreated. Diabetes, cardiovascular diseases can of course lead to significant assistive device need in the future. And of course, it can help improve mobility, hearing, communication, etc., all of which we know is vital in humanitarian situations. Just to say, there's some issues around budgeting for this. We're in a situation where funding cuts are brutal. There's no real agreed definition of what amounts should be funded, and ISE guidelines are a bit vague on this. Some people say up to 1% for non-food and assistive devices. In this guidelines, it says consider up to an additional 3 to 4% on top of funding, but it's a bit of an unknown figure. So that's also a challenge, the cost of devices. And at this point, my Global Disability Innovation Hub colleagues would say, because there isn't such a wide availability, for example, the cost of a hearing aid, the unit cost can vary widely depending on which country, but the more people that need them, the more production there'll be, and the more the cost will eventually go down. So this is something that my colleagues on the 80-20-30 programme are really working on to try and reduce the costs of. Just a few other WHO resolutions, just to really underscore this isn't a new area. It's been around for quite a long time. The commitments in the WHO from their resolution on assistive technology, the next slide please, draft resolution on rehabilitation and the global report on assistive technology all underscore the importance to really include assistive technology in humanitarian crisis. I forget now how many years ago, I think it's probably almost come up to 10 years ago now, there's the World Health Organization 50 priority products list. It's not specifically for humanitarian emergencies, but it's just 50 priority products in terms of assistive devices. There's been some moves from UNICEF to include assistive technology and devices in their procurement catalogue, but again, it's probably not enough as it stands. Next slide, please. Other progress, some of you might already know about the WHO 80 kits, 86 in 10. These were kits, the 6 isn't so much commonly used now, that was for use in health facilities. And the 80-10 kits contain 10 vital, most vital assistive products identified as those most in need in emergency care. They include things like pressure cushions, catheters, incontinence pads, as well as wheelchairs and crutches, etc. These are piloted in Ukraine, and again, with some good results. I guess the challenge, and I'll come to Ukraine in a little while, is these are very much based at the healthcare system level. They're not based really, people could be given those products and go out into the communities, but it's very difficult once people have gone out into the communities to know the impact they're having on people's lives. Next slide, please. This is an impossible to see slide, sorry everyone, but the point really was just to go and give you an idea of the scale of need and the scale of unmet need. So it's probably an obvious, this paper's published in, I can give you the reference after, it's on the bottom of the slide if you're interested. But the point really is there's a huge gap in unmet need. At the beginning of when we first started our work in 80-20-30, we used to say it was about somewhere between 1% and 3% of need was met, hopefully slightly higher now, but nevertheless, we know that there is a massive unmet need. A lot of this need, and I'm looking at you, Oscar, is glasses, eyeglasses. And we probably don't think about those as being any kind of life-saving assistive technology or devices, and maybe they're not. However, if you can't read instructions, if you can't read information, if you can't read where emergency exits are, that will significantly impact your ability to escape or be rescued. So glasses, spectacles, skews this data hugely. It's the most commonly needed assistive device. Probably at least half this room have got spectacles or contact lenses probably. But it's not the only one, but it does skew the data somewhat. And of course, eyesight and hearing do gradually deteriorate as we get older, as my colleague has pointed out earlier. Next slide, please. Okay, so we have a lot of things happening, but what does it all mean in terms of what's happening on the ground? I guess from our perspective, there was very little attention on how AT turns or supports rights. We've heard a lot about the need for rights-based approaches. There is a UN Convention on the Rights of People with Disabilities that covers people with disabilities of all ages. I come back to my point. Not all people with disabilities are old. Not all older people consider themselves to be disabled. However, would have rights under the existing UN Convention, and if you get a convention on the rights of older adults. However, we don't know if it's actually benefited people. There is almost no evidence whether it's what the most effective is and whether it's really having any impact on people's lives. Again, coming back to, I think you said this in your defense yesterday, it was one of the questions, right? If there's no evidence to support doing it, should we do it? If there's no evidence, does it mean we should or shouldn't do it? I would argue we should do it because it's a right. Most of the reviews that have been available tend to look at physiotherapy or occupational therapy provision. And of course, they usually highlight the positive benefits. But what they also highlight is how ad hoc most of the provision is, and it's really not comprehensive. It's probably mostly a few NGOs, often sometimes faith-based organisations, providing some very minimal goods or services. But, and again, most of the data we do have is on very much on immediate post-surgery needs, not really on longer term impacts over time. Most of it, unfortunately, does have a very one-size-fits-all approach, somewhat literally and metaphorically in this set of circumstances. You'll see horrendous, we heard somebody, I think Ria, you touched on this morning, badly fitted assistive technology or devices is actually sometimes worse than none at all. It can cause horrendous problems for the user. Most of the data around assistive technology doesn't really speak about intersectional aspects, particularly aging, but also location, age, etc. So we don't have such good data. And of course, we know about the gaps between what people think at headquarters, all these lovely tools and guidelines that I've mentioned, but actually getting it disseminated on the ground is a different challenge. Next slide, please. We did some work some time ago now in camps in Bangladesh and Jordan. And I guess to reiterate the findings really, but a couple of things I really want to draw out, that we know that just providing assistive technology doesn't support inclusion, but without it, people really aren't included. So it's a bit of a chicken and an egg. Also, the provision of devices, so to take a very concrete example, giving people wheelchairs in the Cox's Bazar and in the camps around Cox's Bazar, very mountainous, very hilly, very muddy. Even with a wheelchair, people still couldn't go out of their immediate environment. So great to have a wheelchair, at least it enables a bit of mobility, but it doesn't actually enable you to go to work or go to school. So we have to think about this in a much more holistic fashion. So the other thing I want to highlight is to really highlight the need for thinking about how assistive technology is both integrated in healthcare systems and wider. Most assistive technology comes under rehabilitation budgets. And again, you don't need me to tell you, they're probably the smallest of all the Ministry of Health budgets, unfortunately. And yeah, to highlight the evidence. Next slide, please. With all credit to Help Aid International, sorry, Ria, I've stolen your slides. I just wanted to, these were the most recent evidence I could find about needs assessments of older adults. These are, this one, Myanmar, is from the earthquake most recently. And I guess the two things to draw out really is both the chronic disease prevalence, which again, highlighting diabetes, heart disease, can all turn into conditions that will need assistive devices and products. And of course, the existing gap in availability. In Myanmar, only 11% of people reported having the necessary assistive products they needed. Anecdotally, and really you may be able to confirm this, it's actually very hard to get assistive products into the country. So a lot of the work we've been doing with the AT 2030 programme is really trying to support local production and sustainable production, and really trying to think better about how to reuse and develop and grow local capacity, both for innovation, technology, and for recycling, because it's not realistic to keep producing things in one country and shipping them in vast amounts to another country. That probably is the challenge. In Lebanon, next slide, please. Similarly, at least 38% of older people reported having one type of disability or another. Again, huge unmet need. 17% reported needing a hearing aid, more than 50% needed glasses. I guess one thing to really highlight that struck me about Lebanon was the number of people living on their own. And this is really an increasing pattern that we see. And yet, almost everyone we spoke to in Jordan and Bangladesh, not in addition to needing assistive devices, they also needed somebody, usually a family member, to assist them anyway, to help them with their daily activities of daily living and their care. And we've heard already the importance of family connection. What happens when you don't have that family connection, when you're living on your own? Who is providing that care? Who are providing those services? Next slide, please. And we've already heard a lot about Ukraine being the world's oldest humanitarian crisis. Certainly, I know colleagues of mine that work on ageing, we've really moved to try and look away from, to focus more on this idea about fragility and frailty. And I think this will probably be something that might come into some of the discussions to try and move away from the issues I think you were highlighting, Flavio, about talking about older and older adults' care. Again, we know that people in Ukraine tend to be older, that many of the people who could flee were younger and have obviously left, leaving behind a lot of older people, particularly in the most war-affected areas. I think what I wanted to highlight in this was an interesting aspect. I've touched a little bit upon social care and disability payments. Obviously, in many humanitarian contexts, this doesn't exist. This doesn't exist at all, but it does exist in Ukraine. And the idea is to help people to access this disability support payments in order to either get some personal care or support. But actually, the process to apply for this is so complicated that many of the older people said they actually just didn't bother. And the numbers of people applying for it are actually dropping. So where the number of people, older people who may need assistance is increasing, the number of people that are actually formally applying for state aid is actually decreasing, because the process to prove your need is actually very complicated. And I think this just highlights how we're assessing people and the kind of processes we need to think about how we assess people for both, whether they need assistive devices or other supports or aid. So it just to sort of think about this, how to apply for this kind of aid and barriers. The other thing, something struck me, and I can't remember who was, Ria, I think you were talking about the veterans and the sort of older adults. And I think this is something we've seen in a number of countries for people with disabilities. Oftentimes, when there's a large number of disabled ex-combatants or veterans, a lot of attention and resources gets put to that group of people, understandably, depending on which country. But Ukraine, it's a very obvious group of people. That money oftentimes is money that doesn't go to other people with disabilities. And this then unnecessarily makes competition between different groups of people, all people with disabilities, but with different, how they got to their situation might be very different. And it ends up pitting already excluded groups against each other, competing for already minimal resources, and creates further tensions and barriers. And that can actually end up to really be to the detriment of those groups in terms of donors. Donors then get put up and say, oh, these people with disabilities, they're always fighting with each other. I've literally heard people say that. And actually, it's not that. It's if you put such small resources to specific groups of people, you're necessarily going to create those conditions where people are in competition. Okay, next slide, please. I thought I'd put this because I work on innovation, but I don't really do technology innovation. But I think it's important to say that, of course, there have been some really interesting innovations in this sector. And assistive technology has often been at the forefront of a lot of emerging technologies. For example, text-to-speak translations on your phone, audio and transcription on the slides. We see all of that were innovations that were largely for people with specific needs and have become much more mainstream. So this can really be useful in terms of thinking about people in terms of living alone. We see a lot of this in some of the work my colleagues are doing in Japan in the Centre for Smart Aging, robots to assist people, etc. We're a long way from that in the humanitarian sector. But I think it's worth thinking that there are opportunities for innovation to really help and support people. However, of course, we know they raise challenges around equality of access, ethics and protection, and lots of evidence to show that there are many groups in older adults, and particularly in that group, who are not included in the large data, what do you call it, LLM, large language modeling. The data that is put into program AI often isn't including older people in the first place. So the responses, etc., might not be so appropriate for older adults. And I think it's really worth reiterating that we shouldn't fall into this innovation trap where technology using technology masks underlying structural issues and inequalities. And so we think that technology is a solution without addressing those underlying inequalities. So I would just remind people of that. Okay, last slide, I think. So I guess my plea really is to think about assistive technology in a much wider framework than just provision of crutches, wheelchairs, etc. And think about it in the 5 Ps. We certainly need to build capacity. And here there's been some really interesting work about including assistive technology users themselves in the design, the product innovation, in the iterations of the research around use. But as I say, where we're much less good yet is the impact of that, particularly over the longer term. And there are some nice examples of community-based assessments of assistive technology rather than hospital or clinic-based assessments. Nice evidence of product innovation. I can give you all of those if you want to have some of those. I guess we're getting better at measuring need. Again, some of you might know some of the Washington Group questions we use now to assess functional limitations, particularly in large-scale population level assessments. This is quite specific, a little bit about procurement, assessment, supply, fittings. I guess what we would say, and this is certainly something the WHO are pushing, whether we agree with it or not, is around this idea of task shift and who should be delivering these things at the level of the health centres, etc. And I guess review what worked. I think we're quite good at criticising ourselves, but much less good about what worked and what didn't, why it worked, and what will happen in the future. So we do things better and differently. And I think that's it. I whisked through that.